In this lesson, we're going to use point-of-care ultrasound to help us identify whether or not the left ventricular ejection fraction is normal, or greater than 50 to 60%, or abnormal, meaning less than 50%. Let's start with a case. So a 61-year-old male comes to your clinic complaining of progressively worsening dyspnea with exertion over the past 3 months. On further questioning, you uncover a history of two-pillow orthopnea, paroxysmal nocturnal dyspnea, and lower extremity edema. Remember that POCUS is a tool to answer a focused clinical question and not a full imaging study. I know you've seen this slide before. So if we go back to our case, what might be the clinical question for this patient? Well, a broad question would be, is heart failure the reason that this patient seems to be volume overloaded on exam? And then if we wanted to refine that, we could ask, does this patient have sonographic evidence of a reduced left ventricular ejection fraction? And this is a question that's well suited to answering using point-of-care ultrasound. Now, there's lots of different methods for assessing the left ventricular function. And I think the easiest way to think about these is using layman's terms first. So the first thing we could do is put our ultrasound over the heart and, well, just look at it. And this is called the eyeball method. Not an official method, but is the method by which most specialists and most experienced ultrasonographers will assess the left ventricular function quickly, just by looking at it and getting a gestalt. Now, as we're learning, I would suggest that we have more quantitative measurements, and so we can measure. And one way to do that, probably the easiest way to do that, is by measuring something called fractional shortening, which we'll show on a next slide. We could also measure it, but more precisely, using something that has a little bit better evidence, even if it is a little bit harder to measure. That's going to be our E-point septal separation. And then lastly, we could calculate it. And that would rely on some volumetric calculations using a variety of different views, quite honestly beyond the scope of a point-of-care exam in most cases. However, I do mention them for completeness' sake. We're going to take the next few slides to go over each of these different methods and talk about what we're looking for in each of them and why the evidence might or might not support their use. Let's start a review of these methods by going over the eyeball method, which is just looking at the left ventricle during systole and seeing if we can determine if the ejection fraction is normal or not. So here I've got two pictures of two separate hearts that are dynamic clips occurring during systole. They're at different gains, so the left one is more gained, the right one is probably a bit undergained. But in both of these, we can see that we're looking at relatively the same spot in the heart in a peristernal long axis view, if you can remember your standard windows from the last lesson. Now I'm just going to tell you, for the completeness sake, that the left picture, or left clip, is a heart with a normal ejection fraction. And the one on the right is a heart that has a severely reduced ejection fraction. Now, I think if you just look between these back and forth, you might be able to see some of those differences in the motion of the heart, in the movement of the mitral valve, and just the overall contractility that may make you feel like you have a good estimation of what the eyeball method looks like. But we do want to put a couple of parameters on our qualitative assessment to help us know and feel confident in being able to say that the ejection fraction is normal using this method. To say that the left ventricle ejection fraction appears grossly normal, there must be these things present. So as we watch the cardiac cycle, we need to see anterior leaflet of the mitral valve having brisk motion, slapping or high-fiving the intraventricular septum in that peristernal long axis view. Similarly, we should see endocardial excursion towards the center of the ventricle, or movements of the walls closer together. And then those walls, or the myocardium, should also thicken during systole and show us that there's good contractility that's actually reducing the volume of the left ventricle, which is the surrogate way of knowing that there's actually movement of fluid out of the ventricle or being ejected from the ventricle during systole. Let's look at these in real time. So if we look at these two images once again, and now we take these qualitative approaches of examining the anatomical findings inside these two ventricles, we can quickly determine that one does exhibit all three and the other does not. So let's take a look first at the anterior leaflet of the mitral valve. So with the anterior leaflet, which is right here, which we know because it's the anterior leaflet of these two, more close to the probe, closer to the thoracic wall, closer to the right ventricle, which is the most anterior chamber of the heart. We see that on this side, on the left image, it is moving briskly and almost seems like it's actually making contact with, or at least coming close to making contact with, this interventricular septum here. Versus on the right, in this decreased ejection fraction, barely opening. And the reason for this is that because this left ventricle has a low ejection fraction, there's a lot of blood retained inside the ventricle that doesn't permit good motion of this mitral valve during diastole. And so it can't open really fully to allow a lot of new blood to come in because it's already filled with blood by not ejecting it from the previous cardiac cycle. The next point is endocardial excursion. We can see the endocardium here is this bright or highly echogenic line that's lining the inside of the ventricular cavity, representing the kind of topmost layer of the muscular walls of the ventricle. And here we see that these two sides are coming closer together. They actually approach the center of the ventricle during systole, during the contraction of the left side of the heart. And that is what we want to see to show us that there's a good ejection fraction. It's like the volume of this ventricle is actually decreasing, which is what makes the blood go out. Versus on this side, we can see the same bright echogenic line here, but they're really not getting substantially close to each other. They're not moving towards the center. And that's a sign that there's poor change in the volume during diastole and systole, meaning that there's not a lot of blood that's actively exiting the heart during each cardiac cycle here. And then lastly, we talk about myocardial thickening. So myocardium is the musculature of the heart wall. And here we can see both in the interventricular septum and this free wall down here that during systole, the thickness that we can see of this kind of hazy gray area is actually getting thicker. And over here in the poor ejection fraction, there may be a little bit of thickening, but it's really not as appreciable. It's really insubstantial compared to the heart with a good ejection fraction. And so you can understand that just, once you've looked at enough hearts, once you feel really comfortable with this is a pretty easy way to just eyeball it and give yourself a good idea about whether or not this heart is contracting well or isn't. Now, this does lead us into a bit of a dilemma because I always try to tell my residents, hey, I want you to take some qualitative and quantitative measurements while you're learning. And so we're going to talk about what some of those might look like in the future. So most cardiologists, most pulmonary docs, most ER docs, and really good family doctors like us are going to eyeball it once we've seen enough hearts to really get a good sense of whether or not the ejection fraction is normal or abnormal. But as you're learning, I do want you to make some actual measurements to help justify your claims and justify your gestalt to help you feel more confident in what you're saying. So if we wanted to be a bit more specific, what would be the next step? Well, I would suggest that the simplest measurement that we could take is by measuring something called the fractional shortening of the left ventricle during systole. Let's take a look at that. So every time I think of fractional shortening of the left ventricle, I often think of this scene from Star Wars Episode 4, where they're in a trash compactor and the walls are getting closer and closer together, and they're trying to sort of prop these pipes up between the two walls to keep from getting crushed to death. And the reason I think about it like this is because this line or this pipe is similar to the line that we're going to be using to measure the distance between these two walls if these are the walls of the heart. So I don't know if that's a helpful analogy for you, but let's take a look at what it looks like on an actual heart. So fractional shortening takes advantage of our good old friend M mode or motion mode, which, if you remember, places a line over one specific portion of the image on the ultrasound screen and traces the changes along that line over time. So here, we want to place our M mode line on the almost perpendicular, if we can, to the left ventricle, and we want to try to catch it through the interventricular septum, through the posterior wall, in a almost, or as close as we can, to perpendicular along the widest portion of the ventricle. And then what we'll do is we'll activate M mode and see a tracing over time. So here's that tracing as it comes over time. And so basically what we see here is this line kind of shows us the differences in the size, the way the size changes in that left ventricle during the cardiac cycle. So here, where this cavity is quite big, this is the height of diastole. This is the largest amount of blood inside the ventricle as it's most relaxed. And then here, with this other line, we have the point where the ventricle is the smallest distance across, where it's contracted the most. We see those same changes echoed up here in the size of the interventricular septum and in the posterior free wall. But basically, what we were able to do is measure the distance between the endocardial lines on both of these points, and we can get a left ventricular end diastolic diameter and a left ventricular end systolic diameter. Now, if those are long phrases that are difficult for you to remember just like me, you could also just call them wide and shallow. And you can measure the distance by which and calculate the distance by which they shrink by taking the wide measurement, or the end diastolic diameter, subtracting the systolic diameter, and dividing it by the diastolic diameter again. Or take the wide, subtract the shallow, divide by the wide again. And that gives you a fractional shortening. Fractional shortening is dependent on sex to a degree, with female hearts generally thickening a little bit more, having a little bit more of a change in their fractional shortening. But a general rule of thumb to think about is that as long as the left ventricle is contracting by about 25% or more, that diameter is changing by 25% or more, that is more indicative of there being a normal ejection fraction. However, it's important to remember that fractional shortening itself, this percentage that you're getting, is not the ejection fraction, because it's a measure of distance, not a measure of volume. So because you're only measuring in one plane, it doesn't give you a very accurate ejection fraction. Now, you can multiply by a factor of 2, and that's a good rough estimate, but it's really not the most accurate way of getting a ejection fraction if you're trying to calculate one. It's really only useful for knowing, is this heart grossly contracting well or not? The fractional shortening of the left ventricular diameter has been used for a long time in the critical care settings like the ER and the ICU, and it's pretty intuitive. It makes sense on a pretty basic level that if the heart walls are coming closer together, if the diameter is shrinking, that means that blood is exiting the heart. But it is a difficult measurement to use sometimes because it relies on you really imaging in a perpendicular plane to that wall. You have to be in a good parasternal long axis view and set your M mode in the right plane, or else you are affected by the way that the cursor might cut across at an oblique angle and overestimate or underestimate some of the contraction. It's also affected in patients that have had wall or septal motion abnormalities, if they have a history of an MI, history of infarct in some degree, or if they have a bundle branch block or are otherwise not having normal electric activity through the heart, which is causing contraction to occur in a asynchronous or unorganized way. It also relies on you getting a really good window of that or that parasternal long axis view. And some people's hearts just happen to sit behind the sternum or right underneath a rib where it's difficult to get that exact perpendicular view that you need. So it is something that can be a challenge. So that's one way of taking a qualitative and quantitative measurement. But there's an even better quantitative measurement that I want you to be familiar with. And this is the one that I actually recommend that all of us learn and utilize at the Waco Family Medicine program when we're doing our POCUS clinic or trying to do an echo inside the hospital. This method is called the E-point septal separation. Once again, getting an E-point septal separation measurement relies on us getting a good parasternal long axis view and utilizing our good friend M mode again. In this case, we're going to place M mode over the very tip of the anterior leaflet of the mitral valve. So we talked about in the eyeball method just wanting to see that anterior leaflet go up and give a high five or a slap to the interventricular septum. And basically this method is a way of quantifying that. So if we place M mode over that anterior leaflet, we can see that over time it has a motion similar to this. So we see that leaflet coming up, doing its little high five. Hey, what's up, interventricular septum? Nice to see you. And then it starts to come down again before returning to its original position. So what this reflects is that in diastole, at the very early diastole, or E, the valve slams open as blood starts to rapidly enter and fill the left ventricle from the left atrium. Then we start to see a slowdown in that blood until we get our atrial kick, and then suddenly the valve closes during systole down to its closed position down here. So let's talk about what each of these points mean one more time, just visually. This is our E point. E stands for early diastole point, and it's the maximal opening of the anterior leaflet of the mitral valve during diastole. This is a part called the A point, which refers to the atrial kick. And then this kind of line up here is the interventricular septum, and this bright white line that's down below, kind of the lowest layer of clouds, if you were imagining this to be a mountainscape with some clouds overhead, would be the endocardium of the interventricular septum. So let's say we trace out an M-mode measurement over time. This line is in the wrong place. Pretend it's over that anterior leaflet of the mitral valve. What then we could do is take a measurement between the endocardium of the interventricular septum and the E point. And the distance between these is our E point septal separation. So you just drop your little cursor on there and you measure this distance. An E point septal separation that's greater than 7 millimeters is 87% sensitive and 75% specific at identifying an ejection fraction less than 50%. And similarly, you can use this formula to calculate a good left ventricular ejection fraction estimation. There are several strengths that make the E-point septal separation my preferred method for evaluating the ejection fraction in patients in the clinical setting. The first is that it's got evidence for using it not only in the emergency room or in the ICU, but also in the outpatient setting, even by practitioners like us that are family practice or junior trainees that don't have formal echo training. It also has limited inter-user variability, meaning if I measure and then you measure, we're probably going to get pretty similar results. It's the least subjective measurement, and it doesn't rely a lot on getting a perfect exact view. If you're off a little bit, you'll still get a pretty accurate measurement that is predictive. It's also a single window view, meaning you're not having to switch your probe around and go to all kinds of fancy different measurements to get all of them together. And it's predictive of a low EF even if there is a septal motion abnormality, because the anterior leaflet of the mitral valve doesn't necessarily rely on the interventricular septum for its motion. It comes from the volume at the end of the cardiac cycle to determine how briskly it's opening and not opening. Now, that being said, there are a few weaknesses to this approach. The first is that the strongest evidence is limited to categorical estimations, so saying that the EF is normal or the EF is not normal. And that's what I want you to be doing to begin with, but I did give you a formula on the last slide where you can estimate the ejection fraction. Just know that the evidence is more supportive of it being normal or not normal and not actually giving you, spitting out like an exact number of saying, hey, this ejection fraction is 42%. And then also, if there is any sort of valvular disease, mitral stenosis, mitral regurgitation, aortic regurg, those things are going to affect the ability of that mitral valve leaflet to actually move appropriately and get an accurate measurement. So if you know a patient has severe mitral stenosis or that they have aortic regurg, those would not be patients where this would be an appropriate way to estimate the ejection fraction. Our last of our standard ways of estimating the ejection fraction is by using something called volumetric calculations, which essentially stands for taking the volume of the ventricle or estimating it using a couple of different windows, and then finding the volume in both diastole and systole and seeing how much it changes. The most common way of doing this is by something called the Simpson's biplane method. This consists of calculating the area based on measuring the left ventricle in the apical 4-chamber view, and then rotating your probe and sliding it over across the chest wall to get an apical 2-chamber view, which is basically 90 degrees from the 4-chamber view. Now, this is much more complicated to get, and studies have shown that it's not necessarily more accurate than using other point-of-care assessments like the E-point septal separation. So this takes a lot longer. It's a more challenging view to get, takes 2 separate views, and it doesn't give us much more helpful information. So while I can teach you how to do this method if you're interested, it's not the one that I'm going to recommend that we do in a point-of-care setting. I'm going to recommend that E-point septal separation is the measurement of choice for us in our clinic system. One last thing that I want to touch on before we close out the section is that sometimes you'll notice that these measurements are grossly exaggerated and that the motion of the heart seems to be more than usual, more than typical. And there is something that I want you to talk about, which is hyperdynamic left ventricular function. So normally in a healthy heart, the left ventricle does not completely empty. It should eject about 30 to 50%, or excuse me, it should eject about 50 to 70% of the volume, but there is still a residual amount of blood inside that left ventricle under normal scenarios. However, there are some disease states which can cause the heart to contract more vigorously or to eject more of its volume with each cardiac cycle. And the things that affect this are decreased afterload. So if there's really no pressure against the heart and the aortic valve against which the heart is pumping, more of that blood may be able to exit during each cardiac cycle. It can also be because of severely decreased preload. And so if there's not much blood moving into the heart or there's decreased venous return, more blood may be exiting the heart on its way out just because there's not quite as much volume to begin with inside the heart. And then lastly, the heart itself can demonstrate a compensation for metabolic perfusion mismatch. So these might be states where there's a high output for some reason, there's a high demand, and thus the heart tries to increase its cardiac output to compensate for that demand. And we'll talk about some examples where that might be the case. So using each of those 3 scenarios I mentioned on the previous slide, we can talk about what some of the clinical scenarios might be that cause this. So a decreased afterload would be things like sepsis or hypovolemia, anaphylaxis or pancreatitis, where for whatever reason there's not much blood volume inside the vasculature because of third spacing, because of an actual hypovolemia, or because of some other process that decreases the pressure against which the heart is contracting. Now, a severely reduced preload can also cause this, and this can also be due to hypovolemia, but more commonly it's due to obstructive processes such as a massive PE or cardiac tamponade. Severe mitral regurgitation can also do this as well. High output hyperdynamic left ventricles can be seen in patients that have long-standing or severe anemia, where although the volume of the blood is normal, the concentration of myoglobin and hemoglobin within it is not high enough to carry the oxygen that the body's demanding. And so for this reason, the heart increases its cardiac output to try to compensate to deliver oxygen to the tissues that need it. Similarly, thyrotoxicoses, sepsis, and sometimes even pregnancy can cause these mismatch between demand or between signals in these metabolic processes that cause the heart to contract more hyperdynamically. So it's something just to keep on the back of your mind as examples. I want to show you what a couple pictures of hyperdynamic heart function can look like though. So here is a parasternal long axis view and a parasternal short axis view on the right of a hyperdynamic heart. So here you can see that the cavity of the left ventricle is almost completely obliterated during systole in both of these images. So these walls are actually like kissing each other, and it seems like they're almost completely emptying the blood volume on the inside during each cardiac cycle. So this is an example of what a hyperdynamic left ventricle might look like. So in review, we talked about 4 methods of estimating the ejection fraction. The first, or the eyeball method, is probably the one that's most commonly used, but it relies on gestalt and on subjective findings to determine whether or not the heart is contracting well or not. And I think that as learners, there's better ways and more objective ways for us to do that. The second is called fractional shortening, where we measure the distance and the change of diameter of the left ventricle during systole and diastole to see if the contraction is happening greater than 25%, and effective at reducing that diameter. And then we've got the E-point septal separation, which is, of course, my favorite child, which I'm not allowed to have of these methods. And then lastly, I introduced you briefly to volumetric calculations, which are ways of calculating the area using a couple of different planes or using a couple of different techniques to then calculate an actual ejection fraction. So I want to finish out this lesson by showing you a real patient case. So this was a 35-year-old female that came in when I was a second-year resident working overnight in the ICU overflow during the COVID pandemic. She ended up coming in the ER. She was put on a ventilator, intubated, put on a ventilator for acute hypoxic respiratory failure. And after being on the ventilator for over an hour, her blood gas was 7.121 for its pH with a PCO2 of 181. So obviously a pretty sick individual. She had a history of coming onto our service and leaving before a workup could be performed because she would frequently leave AMA, unfortunately due to some social determinants of health, including drug addiction, that complicated her hospital stays. On exam, she had some lungs with diffuse crackles and then some also rhonchi, and even the occasional wheeze. She just really had all the possible findings you could have in a lung exam. She had elevated JVP, and she had 3+ bilateral pitting edema of her lower extremities. Now, there was no echo on file in the chart for this patient. She had come in and been on BiPAP before, but had not yet been intubated at this time. So I ended up asking the question, well, could it be that there's a low left ventricular ejection fraction that might be contributing to this patient's hypoxia? And I took the following images. Now, if you're a little bit disoriented, note that our indicator's on the left-hand side of the screen here instead of the right, which is why this image may look reversed. But here we have our anterior leaflet of the mitral valve, and we do see that it seems to be moving briskly, going up and slapping the interventricular septum, and the diastolic to systolic diameter here of the left ventricle does seem to be shortening appropriately. She does have a very elevated or very dilated right ventricle and right atrium consistent with right heart disease, which we'll talk about in our next lecture. But when I did an EPSS, I noticed that anterior leaflet of the mitral valve motion did seem to come into pretty close contact with the interventricular septum. And so I looked at this and I said, I really don't think that there's a lot of left heart disease here. I think this is a pretty good ejection fraction on the left side. Maybe a little bit hyperdynamic. I didn't do an official measurement there of how close the walls are getting to each other. But I think we definitively ruled out that this patient was not having a low EF on the left side of the heart to justify her symptoms, which then turned my question to the right side of her heart, which is where we'll be going next week. And in fact, this case is where we'll start off our lesson with the next lesson in our module about cardiac POCUS. We'll see you all then.